Hello, everyone. Welcome back to another video. And today is going to be kind of a special panel that we have. We are going to be talking about emergency medical services because I noticed that a lot of the medical community just doesn't have a lot of exposure to emergency medical services. And there's a lot going on right now, especially with the current situation, where we have some frontline workers that are doing a lot to kind of get us through this trying time. And so I want to make sure that we offer EMS workers a voice in what we're doing within the medical community and just kind of expose, I know a lot of my audience are medical students, kind of expose medical students to how we can interact better with EMS workers and kind of how we all fit together as one healthcare team. So I have a panel here. I kind of want to go around the room, introduce yourself, your pronouns, your EMS certification or your role and your years of service. We'll kind of start with that, and then I'll add some more questions as we go. So, Mike, do you want to go first?
Sure. I'm Mike Raymond, he, him. I am an EMT working in the greater Harrisburg metropolitan area. I've been doing this for about 5 years, and I wrote my master's thesis on sort of improving or at least analyzing and identifying weaknesses in the EMS system in the Harrisburg, Dauphin County, Pennsylvania area.
Awesome. And I wanted to bring on Mike because of that experience and that research. So you're definitely going to have some good things to say about this. Lily, do you want to go next?
Hello, I'm Lily. I use she, her, and they, them pronouns. I started out as an EMT volunteering in New Jersey. That was about 3 years ago. I recently became a paramedic in May, and now I'm working in Allegheny County, just outside of Pittsburgh.
Awesome.
Congratulations.
Yeah, congrats on medic. That's a big step.
Thank you.
Let's just kind of go around the horn, I guess. Coop.
Yeah, hi. Geoff Cooper. Coop because I spelled Jeff with a G. It's he, him. I'm a paramedic in Dauphin County. Mike and I used to be partners, and I've read and was there through the rewrites and all that of the thesis that he mentioned, and it is, it's good. I'm not going to bullshit you. I got my medic in 2008, I think. 2008, 2009, somewhere around there.
It's been too long.
was an EMT for a while before that, and the last time I was on a fire truck, you were actually allowed to ride the back bumper. So that should put things in perspective, like 1990. And then that I'm a staff paramedic, and that's what I do. I stab people and sell Band-Aids out of the back of a truck.
All right.
That's great.
B's up next.
I was an EMT. I became an EMT in 2010. Did it for 3 years. I worked for a few companies out of Columbus, Ohio, and unfortunately had to go back to being a truck driver due to health issues with my partner at the time. So that was kind of crappy, and I miss it. And I should have, but of course, you can't do continuing ed when you're in a truck traveling around the United States. So I lost my certification. And since then I've been in and out of the medical community. And right now I work in a doctor's office.
Awesome. Well, you all know me. I'm Ben. This is my channel. I used to be an EMT, which is kind of why I was interested in this topic in the first place. I think it's great experience for anyone that wants to get into the healthcare field, but maybe doesn't want to go to a lot of school just yet, or just wants to figure out what they're doing. EMT is a great way to go. I've only worked in private ambulance, so I don't have a whole lot to say. And so that's why I have these other people here to kind of fill in some gaps. But I kind of want to ask another kind of round the horn question. What got you interested in EMS as a career?
Well, in my case, I had served in the military. I went to Afghanistan twice, and my job was largely causing the ouchies, and part of me wanted to be on the other side of the fixing of the ouchies. So there was that, and just general medical interest. My mom was in the medical field, so I figured, what the hell, I'll give it a shot. And everything sort of worked out.
I think I'm
Awesome.
pretty much the youngest one by a lot here. I'm currently a senior at the University of Pittsburgh. So I kind of like had an interest in going to medical school, but I knew I like didn't want to fit that like traditional path. So I think like EMS was a pretty good way to go. Like instead of just going through like 4 years of undergrad and then like immediately going to medical school, having this like way that you can get exposed to medicine and like see everything, and then like once I'm ready apply to medical school, that's what really drew me to EMS.
Yeah, for me, well, there was a lot. I mean, I did start with the fire service. It was a volunteer, Jolly Volley Blue Light Special. Back in the 90s, and part of the reason there was to get the local cops off of my back, because every time I left the house, it wasn't a question of if I was being followed, it was by whom. And the joining the fire department put me up to the point where it was like, well, maybe he's not a complete piece of shit. We had in that department, we had one guy that had they actually had the entire EMT certification, and we were all in awe of his vast medical knowledge. And that seemed to have more of attraction to me on the car wrecks and the jumpers off the cliff than moving hoses and busting windows and all that stuff. Like, I didn't, all right, fire's easy, it gets hot, make it cooler, take the oxygen away. This had more of a cerebral challenge for me, and that's where I was attracted. I took a long pause because, well, I had to make a living. But, my situation changed and I got back into it, once I got back here to Pennsylvania.
For me, I've always, my mother was a nurse and then became a teacher, science, chemistry, etc. teacher. And she always loved to help people. And I think it's just kind of ingrained in me. And I always wanted to help people. So it was a way for me, being ADHD, to get a quick education and get into it, knowing that I would never make it through a full college. So that's why I started it. And I really fell in love with it, but just and mostly because every case was different. Every single thing you saw was different. There was none two were the same. And even working in a private service where I picked up older people out of their homes and took them to the hospital or whatever, and it wasn't emergent, just making them comfortable, making them feel like everything was going to be okay, grabbing them an extra pillow, anything I could do to make their day a little better. And every single one of them thanked me, profusely for being so kind to them. And it made me at the end of the day think, hey, I'm doing, even if this is a lower level of it, I'm doing some good here and I'm helping someone. And that's really what it was for me. I've always wanted to help people.
Awesome. So kind of the next question, and I'm going to open the floor to you all just for some discussion. And I'll happily take a back seat because I'm not an expert here. But what is EMS? And along with that, what is its purpose and role within healthcare?
Well, that's the rest of the whole stream here.
I mean, it's very broad, and I can rein it back in if we get too far into the weeds. But the thing is to have you all talk and share your thoughts. So I'm happy to take a back seat and just kind of moderate.
Well, Mike's going to wait because he's got a lot to say as soon as his face hole opens. So as far as what EMS is a odd little offshoot of the Department of Transportation, where the people that are in it have Department of Health provider numbers. If that makes no sense to you, well, congratulations. Now you're actually starting to understand. It is because of the Department of Transportation Association that we're most often left out of medical, decisions where we don't have a national office. We don't, Surgeon General doesn't mean fuck all to us. It's more because, we're really not healthcare. We're kind of a lied-ish healthcare-esque. You have to put so many caveats on it that it's not even funny. That's the introduction to it. Once you can wrap your head around that we're not actually healthcare, but we're more Department of Transportation, and that's where all of the problems come from, in my opinion. That grasping that will lead to better understanding, and understanding why that is. Now, there's people that went to school for that, and I'll let you guys talk about that.
So in my opinion, one of the issues with EMS is that you have what we would call in a military situation, you have like a strategic level and you have a tactical level. And you can think of EMS in both of those ways, where you have the tactical metal or area where this is where we're actually doing the work. This is where we're treating patients, and this is where we're figuring out what's going on and transporting to the hospital, and the operations side of things there. It's what I like to call complex problem solving with dire physical consequences, where you're doing it with two people, if you're lucky, and that's for only part of the call, with less equipment and other resources than you would have in a hospital situation, and having to come up with a pretty good idea, if not definite idea, of what's actually going on based off of an incomplete picture of your whole scene and everything, coming up with a treatment plan for that and doing it at 65 miles an hour. The other side of it is the strategic level, where we're talking about the big idea of EMS, where it's the EMS system and how the different agencies interact with each other, and how EMS interacts with the hospital systems and the nursing homes, and the multiple tiers of medicine from the street all the way up through your level 1 trauma center, or your Johns Hopkins or whatever like that. And those things are arguably more important than the tactical level, because it sets up everything for that. If there's not good cooperation, then and anywhere in that strategic level, your tactical level is bound to stumble, and a whole bunch of bad stuff happens. So I feel like that sort of answers the question, but it's a whole thing. That's really the only way I can put it. It's a whole thing.
If that question was easily answered, we wouldn't need a whole panel to address it.
I mean, I guess that's the case.
Facts. Absolutely. And one of the problems I ran into being in private EMS was that the hospitals don't take you seriously. They treat anybody that is not connected to a fire department as just, ambulance drivers, wheelchair driver kind of people. And in my experience, I've seen some crazy shit I didn't think I was going to see doing private EMS. So it's not always the case, but I clearly remember standing in the hallway with a patient attached to the monitor, and for 2 hours while we waited for a bed, because they didn't think we were emergent. And it turns out that I can't remember exactly the diagnosis for him now, but the paramedic I was working with was correct. And he had to have some kind of surgery done. I think he had to have like a stent or something put in. I don't remember what it was. It's been too long now. But that's the thing, is they don't take private EMS seriously. and sometimes they don't take the city EMS that is attached to the fire department seriously. If you come in there with a fireman, they pay more attention to you, but that's not how it happens. So
I think that's really area dependent, maybe. Like I could see FDNY EMS, sure. I could see maybe
yeah.
Chicago Fire Department, Seattle. But if you try that stuff if you try that stuff in Dauphin County, Pennsylvania, if you come in as a firefighter EMT, being that they're all volunteer, generally what I have seen is it's the exact opposite. They either get laughed out at and said, you have no idea what you're talking about, and not for nothing, but it seems like a lot of the times, again, being that volunteer status, that it does kind of come off that way, and it is generally like that. And that's a whole separate issue of EMS, of whether this is something that's, you get what you pay for, or if it should be a volunteer service. I'm very much of, if you're good at something, never do it for free. But
absolutely,
that's just me. Like I work for a private agency that's hospital based. If you really want to split how EMS agencies work, you can break it into government versus private. And that private contains hospital based, it contains nonprofit and for-profit. Government-based is either fire department or third service EMS, where it's just, you have the police, you have the fire department, and then you have EMS. It's its own separate entity. So around here, where Coop and I work, it's all volunteer fire and private services, and a combination of both private nonprofit and private hospital-based. Where, like I said, I currently work for a hospital-based system, where I feel like at the hospital that I primarily transport to, that I'm affiliated with, we get taken a little bit more seriously than we do other places. But I feel like that's largely because they're going to see me 7 times that night. At least.
Yeah. And they know, they know you better, but no, yeah. And you're right. It does depend on the hospital. It absolutely does. We would go to one hospital and they would, the doctor would listen to us and hush the nurse, and that happened frequently at and that was Riverside in Columbus, because they listen to everybody. They know that every little piece of information matters, even if it is a small piece. But there were 2 ERs there that would let us stand there and wait with a patient for hours. But it was the teaching hospitals that did it mostly.
Kind of adding on to that, like Allegheny County, Pittsburgh has like 15 different hospitals, 3 different level 1 trauma centers. And it's kind of like, if you bring a patient to like those really like elite hospitals that have like specialties and everything, they'll be like, why did you bring me this fall? And it'll be like, because the patient requested that, and like, I can't go against that. So like, they kind of like don't want to take your like less serious cases, because like it's not.
We
like,
brought him here because the turkey sandwich drive-through was closed. So
yeah, I mean, the other side of things, like putting aside what agency you work for or not, sometimes I've gotten from hospitals when I say, hey, this is what I think is going on. And especially as an EMT, if I were a medic, I might be taken a little bit more seriously. But I've personally been told, and I've seen medics be told, you're just a technician, you're not a medical provider. Which, sure, by the letter of it, yeah. But we're acting autonomously, where you nurse, need orders, or you, no offense, medical student, need permission from daddy. It's a whole thing. Like, I've had multiple times saying, well, maybe you need to go back to school and get more education. And I'm hearing this from, people with BSNs, and again, not for nothing, but I have more education. I've plenty of education. Please do not tell me what I do or do not know. I know exactly what I do or do not know. Listen to what I have to say to you.
Right. Well, I mean, there is that. And I think a lot of it is that they don't understand even if they realize that interventions are performed outside of the hospital theater of operations, that, I tubed this guy upstairs in a hallway coming out of the bathroom
with no light.
Yeah, with my feet up against the wall in like some like kind of weird downward dog facing dog yoga position to try to get an 8-0 in the son of a bitch's throat. Right. Oh,
and then you carried him down the stairs.
Right. And then we extricated him through 3 floors. Okay. Right. And you're gonna say, oh, well, why is he bucking the tube? Because you got the paralytics, okay?
Because I can't knock his ass out the way you can.
Right.
That's why.
But you get that at every level of medicine. I think that, wherever you are working, if you can't learn something, if you're in medicine, if you're working, and you can't learn something in that position, then you need to not be in it.
Absolutely.
And that goes for, the burnt out ghetto medics and, to your first year EMTs, to your third year residents, if you don't understand how I diagnosed a PE in the field and will fight you for your paycheck on it, okay, we can have that conversation. But don't tell me I don't know what I'm talking about in front of everybody else. You want to have that conversation? We can have that conversation, and I can show you why I would say this is a VQ mismatch. I have no problem with that. I'll also tell you what you're going to find on the ultrasound when you put it over a right atria, okay, based upon the right-sided JVD.
A lot of what we're doing,
we have to work. We have limited tools with which to work, and we have limited formularies. But
they're all pretty low tech.
Yeah.
And I think that's a big part of it is hospitals seem super, super dependent on technology right now. Every single person gets a head CT. All of them. It's just this, you came into, this trauma center. Here's your head CT. Here's your complimentary head CT. Enjoy.
After the 5th one, you get a free burrito.
Whereas how can you tell this person has a long bone fracture when it's not necessarily displaced? Well, I auscultated it. What do you mean you auscultated a long bone fracture? Well, that's a thing that you can do.
Do you guys ever wonder? Do you ever wonder, if our power grid shut down, do you know how important you guys would be? Because they wouldn't have all that technology to take care of them anymore. They would have no idea what to do. Because they've all been taught how to use the technology.
Well, I don't know how Ohio works, but here in Pennsylvania, and these guys, will attest to this, that, an ALS service, where a medic is required to have end-tidal CO2. And we can use this monitoring on every respiratory patient that we see fit. We don't have to call anybody for orders. I don't like how you're breathing. I don't like how you're breathing. I'm going to put you on an end-tidal cannula, and I'm going to look at the waveform.
Yeah, Capno is very underused.
Our ability enabled to, our familiarity with it, and our ability to monitor that places us at actually, the rare technological advantage that we have over your garden variety ED room. Now, are you going to have that in, Trauma Bay 1? Sure.
Yeah.
Are you going to need 444 people in that bay to get that technology? Also sure. And like Mike said, one guy can do that at 75 miles an hour while sitting backwards.
So I do want to, for the audience, just kind of, there's a couple questions I want to get to just because of things we've already talked about. But what are the different levels of EMS certification, and what education do you need to get to those levels? Because I hear I feel like people don't really understand what it takes to become a paramedic. There's a lot of work that goes into that people don't really see. So just for the audience, kind of what does it take to reach these levels of certification. And I know a lot of this ends up being like state-based because everyone has different requirements, which is kind of why I wanted multiple people on this panel to talk about it. So for your system,
and you got 3 of us here in Pennsylvania, so
oh, okay, well,
right. I mean, Lily's out on the other side of the state, from where we're at, but I mean, we're still all here in Pennsylvania.
I mean, it's not too different across the board. Like, I think there's some differences, but I think for the most part, there are more similarities. So, kind of, yeah. What does it take to become an EMT or paramedic where you're at?
Well, I think even before that, you have the first responders. You have the EMRs. Pennsylvania has an EMR, and I will be honest, I'm not entirely certain what the requirement level for that is.
I think it's 200 hours of training.
Is it 200? Does that
so.
check out for you guys? Oh, okay.
Let me look real quick.
EMTs, what, like 600?
I think. Let me look real quick.
I can't speak on it because I'm not up with the new stuff. I mean, when I was in, they were about to get rid of intermediates, so I don't know where we're at right now.
And it's funny because Pennsylvania is just actually implementing intermediates. Like they're just starting to do.
Really?
That. Yeah.
Well, advanced EMTs.
Okay.
Yeah, Colorado, where I got my EMT cert, which is expired now, but I did mine in 2017, and Colorado doesn't really use any intermediates because the scope for an EMTB is so broad that there's really no point in having anything in between a basic and a medic, because you might as well become a medic if you're going to do anything higher than that. So I think mine, I did like a summer class, but it was like an all-day thing. So it's probably the same as a semester, but it was over fewer months for the summer class. Mm-hmm. But that was mine to get my EMTB. And then we had to do like I don't remember how many clinical hours we had to do for that. And then we had the field internship with the ambulance.
Right.
So right. My best analog to explaining EMS education to traditional like college education is an EMR would be like taking a course over a summer semester, like a shortened summer semester. EMT would be like taking, I'd say, 4 or 5 classes over a semester. And a medic is more comparable, or it was more comparable. They keep shortening it to like an associate's degree. And then you go on to your other specialties like critical care, where that's, again, a whole nother thing. That's tons and tons and tons of math and chemistry and physics mixed in with your EMS stuff that you have to have a sort of baseline understanding of, whereas this is more advanced application in critical care.
It could be interesting to talk about like the scope of the different levels. I don't know if you guys use AEMTs a lot in your service. We do. But like we kind of use it with like supervisor backup, because any like cardiac call, you can't really use an AEMT. So, yeah. I guess EMTs can do like, I guess, basic life support, give aspirin, oral glucose, oxygen.
Yeah, they can give most of the oral medications.
Yeah.
That are going to be emergent. Your cardiac meds, your glucose. I mean, because this is stuff that you can give by mouth that if you don't, could be bad. But they're not. It's not going to be any oral, like real comfort measurement medications, like Zofran, is not. But why not? Don't know. But it's not going to be any IV medications or anything like that.
Yeah, EMTs in Colorado, we gave Zofran all the time. Like that was within our scope, including IV Zofran. So
in Pennsylvania, we give alcohol prep pads.
Mm-hmm. Yep.
Sniff this. Tell the person, hey, this, I mean, by the study, this works technically better than Zofran does. I know it's not going to seem like it, but trust me, this is a thing. And then
I have
people look
heard
at
him
you like
say
you
this.
have-
I can't tell you how many times.
But it works. I mean, it cuts through nausea some of the time.
Yeah.
It's a big thing in New Jersey because it's only BLS trucks.
Yeah. Like, so where I'm working now, they're talking about, and I'm trying to convince my upper level management to let me do a research study into this, of our current deployment is MICUs, where we'll have a medic and an EMT on a truck, and then just BLS trucks where it's EMT and EMT. What they're talking about going is towards intermediate units where you'll have an AEMT and an EMT basic, and then BLS units where you'll have an EMT basic and an EMT basic with ALS chase. So you'll have a paramedic in a squad where, if needed, they'll go out to whatever call they're requested to, or if it's just something that seems like it's going to require it. Which I'm curious as to a multitude of things that I want to look into regarding that I have written down for the next time that I see them to ask about it, if I can find it in my notepad of endless patient information and ideas, which who the hell knows if I'll find it.
Yeah, I mean, the training, the scope of practice, and the abilities that each tier brings to the patient and to the whole thing is, you need them all. You need them all.
Especially with the shortage of medics.
Right. I mean, they have been, as Mike was saying, they have been reducing the education requirements for paramedic, at least in the Pennsylvania.
We forgot to mention PHRNs.
Oh yeah, we got the Ferns. Yeah, the Ferns. I mean, you take an RN and then you add on another year course of how to operate in the hospital. And these are all the things that you can do outside of hospital that you're not allowed to do inside a hospital. Here, go ahead, stab an EJ. Here, cut a neck. Drop a tube.
Without any of the sort of apprenticeship information that you gain as an EMT ahead of time. Like, hey, here's how I work a stair chair. Here's how I work a stretcher, period. I've watched Coop be like, okay, you want to learn PHRN things. Step 1, take the stretcher out of the truck. And then watch as they scratch their heads. Like, you want to do all of the cool,
but it won't come
stuff.
Out.
You want to do the synchronized cardio version.
PHRN, I say red handles move shit. I can't tell you how many times.
You want to do the synchronized cardio version. You want to intubate all the people, but you don't want to learn how to manage a scene, and that's arguably the most important.
It is absolutely the most important thing, because you don't have a patient to manage if you don't have a scene to manage. You're like, if you can't manage the scene, then whatever you're doing for the patient is pure dumb luck that you got there.
And this is something too that I think a lot of people just don't think about with EMS, and that is, you're not in this controlled environment all the time in the hospital. Like in the hospital, you don't like you're saying, you don't have a scene to control. You have other people that handle keeping the hospital as a safe place where you can just kind of go about your business. When you're pre-hospital, you have a scene to manage. You have other people that are bystanders that are doing whatever they're doing. You have cars moving all over the place. Like you might be in the middle of a road doing a code. And I've done this. We had a guy going to cardiac arrest in the middle of the street, and you're responding to that. You have so many other factors involved, and EMS has so many other things on top of medicine that they have to work with. So like, don't underestimate the ability of EMS to handle a scene and to be in a stressful situation.
Well, I mean,
Yeah.
and also, I mean, I don't think it could be overstated that the scene that we're talking about here in EMS does not end at the time that you leave where you were dispatched to. The scene continues through until you actually transfer care. And that can deteriorate at any time because
Yeah, and I know
I
that
mean,
personally.
I have legit caught a foot to the face while on hospital campus.
Was there.
He was,
Wow.
you know,
Yeah.
and so it can deteriorate at any time. So
Yeah, and it's
for
a lot of it's
why, you know, some of the methods that we have that are necessary to be used in the pre-hospital setting could, you know, seem excessive if you're inside. But when it comes down to it, I need to go home at the end of the shift and keep going home until that Thursday where I get my paycheck, you know, and I need to ensure that that keeps happening. If I have to, you know, tie a patient to the litter, you know, or, you know, jab an 18 gauge, you know, full of ketamine through their jeans into their thigh, I'm going to do that because I like to get my paycheck and I don't like to get kicked in the throat. It hurts. It makes my voice sound weird.
Obviously, you know, using words is the first step. If I can get somebody to calm down and I don't have to do anything, that is ideal. I would personally prefer that everybody just treat each other with respect. However, that's not going to happen, especially where I work now. I work in a city environment, and that's not going to fly. It's a lot of trust with your partner. Like when I worked with Coop, if he was with the patient, okay, you worry about patient stuff. I'm going to keep figuring out what's going on around us while setting up our exit so that we can, you know, extricate this patient quickly and safely, while, you know, kind of keeping an ear out for what's going on with the bystander. I know that our old supervisor ended up getting roughed up pretty good a couple months ago on a call because he was treating the patient in the ambulance before going to the hospital, because sometimes, you know, it's a lot easier to do when you're not moving. And the patient's husband felt that we weren't, or well, not we, I wasn't there anymore, but he wasn't moving fast enough, came into the back of the ambulance and started beating on him. And if there's no cops already there, you've got the 3, 4, depending on where you are. If you're in, you know, more of our rural districts, you're waiting 30 minutes on the state police to figure that out on your own. There is no hospital security. The police aren't always there. It is you and your partner, and that's what you have. And the with your partner is only for the part where they're in the back of the truck with you. So, like, I mean, you hear about hospital staff getting assaulted and whatnot. The same thing happens on the other side of things. It's just there's no one to help. No one is coming. It's up to you. And figure it out. It's sink or swim. It's a constantly evolving environment where 1 second everything is copacetic, and the next, you know, well, screw you, man. Why'd you ask me, you know, if I had, you know, done any drugs or drank anything? What are you accusing me of? Absolutely nothing. I just need to know so that I can tell the hospital so that they, you know, don't mess you up, or so that they can speed things along instead of waiting on a talk screen to come back before doing anything. If I can tell them, yeah, you smoked some crack, or yeah, you smoked some pot, that matters. But, you know,
it all matters.
Yeah, and it's not even the what the patients tell us, because everybody lies. Absolutely everybody lies, and it's adorable that they think when I don't know that they're doing it.
Right. Yeah, they just had 2 beers.
More often than not, what I find the most relevant is what people don't tell me.
Mm-hmm.
Like, I'm going to ask you this question. I already know the answer to it, but you're not going to tell me. So what else aren't you telling me? And then it's anticipating people's behavior. It's what are you going to lie to me about? What are you going to tell the truth to me about? What's the advantage here for you? It's like complex problem solving with dire physical consequences. And hopefully the dire physical consequences aren't for me.
Yeah.
Even just like medical history, like sometimes nurses will be like, why didn't you tell me they had end-stage kidney disease? And I'll be like, because they didn't tell me that. Or like the classic, like, what medical problems do you have? Nothing. Like, what medications do you take? Oh, like all these medications. I don't have medical problems because the medicine solves the problems. Like,
yeah, I don't have high blood pressure anymore. My doctor put me on lisinopril.
Or the problem that changes when you get to the hospital. Like, this person has no complaints whatsoever the entire ride to the hospital. They just want to be checked out. We get to the hospital. Well, my neck is killing me. Are you absolutely kidding me? I just asked you this 6 times 5 minutes ago, and now you're changing your answer. So I look like a jackass. So,
well, I mean, I can't tell you how many times I've said during transfer care that the patient's symptoms were exacerbated by the proximity of medical personnel that appear to be empathetic to their situation. I've said that in the trauma bay at Hershey.
Yeah,
it's recorded somewhere.
No, it's true though, and people do that all the time.
Yeah.
Like they think that they have to tell the doctor, nobody else, the doctor stuff. They do it to nurses too. And when the doctor walks in, all of a sudden I have all this list of problems. They do that at the practice I work at right now. I need to see the doctor. I got a rash on my ass or something. And then they go in there and go, oh, I forgot to tell you, I've had bleeding from my rectum. I've had, like,
right. Yeah.
That's not what you told me.
I had a patient tonight who she threw her back out and it looked like it hurt. She was having spasms and everything. She got some Toradol and she ended up overall, by the time we transferred care, getting 100 of fentanyl. Okay. Her daughter was there when we opened the ambulance at the hospital, which I detest, but whatever. And she said to her mom, make sure you tell them that you're having 10 out of 10 pain so you get seen faster.
No.
Ambulances are not the
pain
way
is not emergency.
Correct. And ambulances aren't a way to skip the line, and everybody and their mother seems to think that, up to and including the hospital.
Especially right now, the 7-hour wait times.
Up to and including the hospital, because lately an issue that I've had at work is hospitals calling into us, because we do interfacility transports as well, where we're taking person from hospital A to hospital B or hospital A to nursing home B. And they'll say, we're going to make this ALS. Okay, why is it ALS? Well, they're on the monitor. What are they on the monitor for? Well, because they are. Okay, but why do they need to be? And like I've seen physicians and just other hospital staff getting annoyed at this questioning. Excuse me for trying to advocate for this patient who doesn't need this additional bill or whatever, but what is a 3 lead going to do for a person who has toe pain? Like, this person's getting a surgical consult for podiatry or whatever. Like, why are they on the 3 lead? Why? Because they think that they're going to come faster, when in reality we have fewer medics, so it's going to take us longer to get that available. On the flip side, if you just make everything BLS, where we send an ambulance, sure, we have the personnel to do that, but if we get there, we're like, the hell no, I'm not taking this patient because it's not appropriate for me to take as an EMT. So now we have to wait for a medic to get here. And
the guy that's on the Levofed drip, you need the medic for that.
Yes.
Yeah.
Okay.
Like, knowing when to tell us to get there fast, like, hey, this needs to go. Like the 2-year-old that we had the other day with a temperature of 105 and a heart rate of 180, that they didn't feel the need to tell us, hey, you should probably be there like yesterday. Versus the stat transport because the hospital is yelling at the dispatcher. I'm sorry, like that's not my problem.
I feel like this is part of the problem of the healthcare system in general, is people you know, they exaggerate, they act like it's not a big deal or whatever, because they think this is going to be an advantage to them. And then you get an ALS run for something that isn't, and
Walk of
then
life.
insurance and the patient, and it's just a vicious circle, and it just keeps going round and round. Now you have insurance companies who don't want to pay for stuff to be done because they think someone's lying to them, because this is how it
People
starts.
are lying to them.
Because people
I'll
are
go ahead and
lying
say
to
it.
them. So we have to fight every day to get a patient. You know, they've had X-rays, they had an MRI. Now we need a head CT. Oh, we don't want to give them the head CT. Okay, well, this person's fainting, has chronic migraines, has blah 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 blah. We fought the other day for one, and we finally got a head CT. I think it was a CT. Might have been MRI. I don't remember. But we finally fought a week and a half. This person had a fucking brain bleed. They didn't want to do it.
Mm-hmm.
And that's how it is now. It's just this vicious cycle that keeps going.
My partner and I had a critical care transfer last night from what we would generally call, like unabashedly, a substandard hospital to a much better hospital.
I know where you started and where you went.
Actually, you don't. It's one further south than you're thinking. This one's in York County. But
York. Sorry.
Yeah,
I still know.
So we get there and nobody's able to answer our questions. This man is altered, combative, and we keep throwing benzos at him instead of answering any of the questions that we have, like how many units of blood has this guy got, and have you given any calcium? Have you tried this? Have you tried that? Have you gotten an updated set of lab values? Keep in mind, we were there at 11:30 at night, and their last set of lab values were at 3:30 p.m. Yeah. So we were less than pleased with the whole situation. And when we're asking for things and not getting them, like, okay, you've tried Ativan, you've tried Versed, you've tried Valium, you've tried Geodon, and none of them are touching this patient. How about we just RSI the guy? Like, it's what's going to be safest for the patient. It's going to be what's safest for the crew. No, you don't want to do that? Okay, well, how about you give us, 250 of ketamine, and if they get real sleepy later, well, we'll just take care of it then. No, you don't want to do that either. Like, so you don't want us to be successful. I'm telling you what we need, and you're telling me absolutely not, but not providing me with a good reason.
Right. Well, they're trying to manage this guy with 2 milligrams of 2 milligrams of Ativan, which I still maintain is not truly a benzodiazepine. It's merely a PlayStation adjunct. And, you're managing him inside with, frequent redosing of PlayStation adjuncts and the side order of you might lean into a benzo if you start sniffing around Valium's back door. But we have to manage this patient with one guy in the back of a truck for however the fuck long we have to be there. All right.
Yeah. Trying to run blood through a 22 gauge.
Yeah.
That sounds fun.
Yeah.
We're stacking these red blood cells single file.
Yes. Oh, are you?
Yeah, just shake them up
technique.
And put them in like a little
We didn't
hopper.
even do that when I was in EMS. How do you do that? Oh yeah, the new blood stacking drugs. Those are great.
Yeah, it's fantastic.
So I wanted to ask, and this is a can of worms that we already started getting into, and this is, this will be the last big question I ask, I think, because this might take us a little bit. But what are some of the biggest problems EMS workers face, including right now with the current situation? And I'm saying, like, because we've already talked a lot with specifically clinical situations, but I also want to hear your thoughts on just being employed in EMS. Like, you are frontline workers. Are you being treated appropriately? What's your staffing like right now? How is administration treating you? Like, are problems in general with EMS?
Where to begin? I could write a book on problems in EMS.
I'll be back.
Yeah, Yeah, he just
I'm
got
going
an
to get
idea.
a refill because I have
Yep.
a pretty good idea what Mike's going to say. So I'm going to get a refill, and I will be back shortly.
Sounds good.
So staffing, there is none. Why the hell would anybody in their right mind want to be a paramedic right now? Your pay is garbage. Your hours are garbage. You get treated like crap from your management, from the patients, sometimes from hospitals, your coworkers. The environment is largely toxic a lot of the time because there's a thought of, one, this is the way we've always done it. Two, why would you want to seek mental health help? Because that's just not the way we do things here. You have to be tough. You have to internalize or, figure out how to put the really crappy call you just ran somewhere way the fuck over here. You have to have several mental diagnoses in order to want to be a paramedic right now is my opinion. It's you have to be some kind of masochist. That said, the ones that I know that are good at it happily, joyfully go off to work and do this because they know that they're good at it and somebody has to do it.
Faith No More wrote a song about that.
What?
Faith No More wrote a song about that.
Oh, well, yeah. So staffing, especially for medics, we don't have any. So Pennsylvania Pennsylvania specifically came up with PHRNs to try and fill the gap, except they're missing a lot of information. EMTs get out because a lot of them see it as a gateway into something else. They'll be able to get their patient contact hours for physician's assistant school or in order to get into the fire department. So we lose people that way. Not being taken seriously by the hospital because the requirements for our education are so low that while we do have, some really good providers, we also have complete idiots who have the same certification that I do, the same certification that she does, the same certification that he does. And, if you've never seen me before, you just know that this is what my patch is, and I know what the lowest common denominator is. It's like there's no standardization of education really across states. Even though there's a national registry of EMTs, we've already covered EMS being somehow quasi-run by the Department of Health, and I can get into that at a separate, or not the Department of Health, the Department of Transportation, which I can get into at a separate time as to why that's a thing, which goes back to federal funding, which is currently non-existent. It's a very, very frustrating thing. Companies fighting over territory instead of doing what's best for the patients. I used to work for an agency that, in the interest of turning a profit, made it so that EMTs could not check glucose. We had no
New Jersey.
Yeah, we had no glucometers on BLS trucks because if we don't have glucometers on BLS trucks, then it's an ALS skill, and that means that we can bill ALS for it. How that's not Medicare fraud, I have no idea. If anybody has the number to report Medicare fraud, please do let me know, and I will happily, joyfully narc on them, although I believe they fixed that problem since my departure. So, yeah, there's a whole bunch of shitty stuff that happens, and then you have, like, some good people who are trying to put in the work and trying to make things better, but because that jeopardizes the way that things have always been done, they're ostracized.
Mm-hmm.
I mean, I'll go ahead and name two people, Coop and I. I don't work where I used to work for a reason.
Mm-hmm. Yeah.
And like, I mean, I changed companies, and it's not that it's better. It's just different problems.
Right. There isn't any greener grass in EMS to go to. Yeah,
it's all brown.
Ask me, there isn't any greener grass. If the grass appears greener on the other side of the fence in EMS, you're looking at AstroTurf because it's false.
And as soon as they pull up that,
it's fake. Okay. If you really believe the grass is greener on the other side, you need to get your ass into some counseling, like quick, which you can't afford because you're in EMS.
And you won't be given because you don't hold a gun every day.
Right. I would say the main challenge that I see with EMS of why we have the attrition of providers that we do, as Mike was saying, to nursing school, to PA school, to the fire department, is because the guy that's driving a forklift at the Starbucks roasting plant is getting paid time and a half, like 1.5 times what the paramedic is, because he's getting paid 3 times what the EMT is.
Absolutely.
Because you have guys that are driving a truck because they can no longer afford to be an EMT. You have if you're going to be staying in EMS, you're either working multiple jobs or have so many side gigs, or you got a sugar mama daddy person, helping support
or you live with 3 roommates. Been there.
Okay.
Or all of the above.
It is the erosion of the support structure that normal people have access to, which fuels this attrition of providers, which fuels the burnout that all of us have. And if you don't have burnout in the EMS, give it another week. One will be assigned to you shortly, along with your recurring nightmares.
7 to 8 business days.
There's a reason that EMS has a provider suicide rate at 8 times the national average. And that's what it comes down to.
I will absolutely tell everybody in the entire world how much I make, because I get the same answer every time. That's it. I make $16.86 an hour. I've been doing this for 5 years. I started at $10 an hour. What I'm making right now for the area that I work in is considered very good. I am told frequently that I should be thankful.
Yep.
I have to, my wife and I own a business, and then we are working on getting our second business off the ground. And that is the only reason that I am able to work in this field, is because we own 2 businesses and one of them happens to be successful.
That's exactly why I had to quit EMS. I couldn't. My partner, who was a paramedic, who ended up with swelling around her throat consistently, being hereditary angioedema. We didn't know that at first. She ended up being trached after years of struggling with this allergy that nobody knew what it was. So of course she couldn't be a paramedic anymore. So she had to stop her $13.85 an hour paramedic job, where she had been a paramedic for 17 years. And I had to stop my $10.25 an hour basic job, and I had to go back driving truck because it's the only way I could make those figures together. And I rarely slept for like a year just to pay bills. And I drove illegally and ripped my logs out, and that's what I had to do. Otherwise, I'd be a fucking paramedic right now.
I know you kept 2 logbooks.
Oh, fuck. No. I had loose leaf. I just threw it out. Started over.
Yeah, like
there was no numbers on it. I bought those kind intentionally. Yeah, but that's how I made 60 grand that year.
Yeah.
That I did that. I paid for everything.
I want John Q. Public, the average citizen, to know that the person who's coming at 2 a.m. in the morning when your mom can't breathe is doing it on no sleep on a 24-hour shift, and who is making what they make to operate in those very frequently impossible conditions, and having to do so with a level of proficiency, or expected to have a level of proficiency, where they're going to be able to correctly identify the problem, come up with a treatment plan, execute it, extricate them from the building, get them in the ambulance, and get them to an appropriate medical facility. And they're making what they make with the amount of sleep and resources that they have, or rather don't.
Right.
That's what I want people to know. I want them to know what we do and how we do it. But I really think that people don't want to think about it. I think that no, I just want it to be there. People have an idea because they watch television, they watch Chicago Fire or whatever, or back in the day, Johnny and Roy. But like, frankly, most of them have no idea what the hell we do. And
We also do so much. Like, we do lift assist, which could be delegated to police or fire. We transport 302s to the hospital, which police officers can also transport 302s, and it would be much cheaper for the patient. Last night I did a high school football game standby, which was basically I did nothing for 4 hours. Like, we have to do all the other stuff too, and that means we don't get to do like the serious emergent calls because we're doing everything else.
Because EMS is a catch-all. Like when they were talking about not sending police to certain problems anymore, I was thinking that's great, but that means that I'm going to do it then, and there's not enough of us to go around to do it. And frankly, like, I can count on, one hand the number of hours in the 5 years that I've been doing this that I've had for psychological training, which it's, hey, here's the trauma that I've experienced. Let me compare that. Let's compare notes real quick, and I'll tell you what worked for me, and maybe that'll work for you. That's what it comes down to.
Sorry.
Go ahead.
Also, I feel like people need to think about there are other factors in EMS, like keeping yourself safe while you're trying to save people. Yeah. My ex-partner came out of the hospital drive. It was a ghetto ass hospital. It was the closest hospital. Of course, emergency, that's where you're going to take them. And came out and stopped at a red light and had a gun put to her head. And they took all her Narcan needles, blah, blah, blah. She just started giving him stuff. Here, just don't shoot me. Do you need needles? Yeah, okay, I'm not looking at you. Do you need tourniquets? There you go. Take those. Here, take all my Narcan. Just take all this stuff and please don't shoot me. And she's on her knees on the ground digging through her medic bag. Stuff like that happens. Stuff like that happens, and it happens a lot, and people don't realize it. Did she get any mental health care after that? No, they didn't offer her anything. Not the company, not the state.
They probably got bitched at for losing the equipment.
Well, she was the captain at the time, so no, she didn't get bitched at. But still, she was the captain, and the company did nothing for her. This huge company did nothing for her. They didn't offer her anything. They didn't offer her partner anything. While her partner's sitting there with their hands on the wheel going, I'm just not going to move right now. I'm going to sit right here with my hands visible. And she was frozen. She just was scared to death. Scared to death. But they don't offer that. They don't check in with EMS workers. They, like Mike was saying, they just don't do it.
I mean, the fact that there should be a continuing education program for EMS providers on what to do when you're faced with the situation of being rolled for your medic bag or being rolled for your dope on your truck or whatever, like how to survive a carjacking for EMS. Like, the fact that there is a need for this class should tell you all you need to know.
The fact that you're not allowed to have anything, as far as I know, unless something's changed. You're not allowed to have anything in the ambulance to protect yourself with.
Right. Yeah.
Yeah.
You
can hit him with a monitor.
Bag.
Yeah, you could hit them with the oxygen bag. That'll kill their asses,
But if I yell BSI scene safe, then I'm fine, right?
Oh, yeah. That's right. I forgot that. It's been so long since I've been in school.
BSI scene safe. I'm
BSI scene safe.
It's all better.
Yeah,
I actually did
a lot of sounds. A lot of this is like knowing what to use when. Like, sometimes there's the time where you have to use the daddy means it voice, and sometimes that works. Sometimes that just makes shit worse.
Yeah.
Coop's done it. I've done it. I did.
Can confirm.
Last night. And a lot of this just sounds like griping.
It is.
But I mean, if you're going to give me a window to gripe, I have nobody else to gripe to. Like nobody wants to hear this shit. No, it seems like, at least, nobody on the hospital side. Like, they'll lend a sympathetic ear, but that sucks. I'm going to go back to, my nurses union or whatever, and enjoy my yearly pay raises. Like, it's
that actually exceed the cost of living increase. That's
Yeah.
the thing. Like they get
Yeah.
like there's people that actually work in healthcare who get like raises like every year, and the raises that they get are actually more than the cost of living increased. It's amazing.
Yeah.
It's like they're doing
Inflation.
financially better year after year after year after year because of how many years that they stay in their job. They keep doing financially better and better and better. It's amazing. I don't know how to get there. I've never seen that.
I've
never
he
seen that.
works and where I used to work, the maximum pay raise we could get per year for our annual performance-based pay raise was I think it's 2.5. I think it's 2.5.
It is 3.
Okay,
Yeah, if
3%,
you got a perfect score across the board, you would get 3%.
which nobody
Wow,
got.
you guys live in a good area. I got 50
Right?
cents.
Right?
Right.
Well, I mean, depending on what you're getting paid, 50 cents might be more.
No,
Yeah.
you're like, oh, you're saying 3%.
Yes.
Yes.
Oh, God. Ow. That's
Yeah.
not even cost of living.
No, it's not.
No.
We're actually losing money the more we stay at the same company.
Yep.
Like, if we're going to do the long math here and show your work, we're losing money to stay with a company.
Where's your whiteboard, Mike? Let's do that. No.
I mean, I do have a whiteboard up here somewhere.
No, it's fine. No,
You will
I
get
actually have to grab
60
my charger
pages
real
of
quick.
whiteboard.
Yeah, I mean, have you ever seen A Beautiful Mind? It'll end up like that.
Right. Good movie, but really psycho.
Yeah, I mean, it's the erosion of the support structure, for the individual in EMS, because you just no longer have access to it. I mean, if you're going to try to make a living working one and only one EMS job, you are going to eat a lot of those Nabisco 100-calorie pack doodads that they have in the EMS room at the hospital. You will know exactly not only where to get the ED turkey sandwiches, but where also to get the salt, pepper, and mustard in facility. This is what you're going to have. I mean, you're legit going to be stealing food to survive.
Yeah.
Because
we used to do it. Hell yeah. We're gonna stop and write these
you're
notes
wind
real
up,
quick.
Putting everything in your gas tank just to get to work. I mean, that's how it's going to be. And that is no exaggeration whatsoever. None. Because I can tell you at any hospital in Dauphin County where to get the turkey sandwiches and where to get the condiments to make the turkey sandwiches that they give you actually decent.
They're
So
on
I
the
have a
bottom
question.
shelf of the EMS room refrigerator at Hershey right now, in case you were wondering.
Good to know. Thank you, sir. Next time I drive through Hershey, I'll stop.
It's the sweetest
Well,
hospital
I meant
on
for
earth.
him, but
I know.
Yeah.
It's just being a smart ass.
B, did
You
have a
made me
question?
laugh. I forgot what I was going to say.
Oh, you forgot what you were going to say. But I do want to ask, because we're in a very unique situation right now. So we know that EMS was already a risky job to have. We already know that you're putting your safety on the line every time you go out on a call. But how has that changed with the pandemic? How have things been for you with that regard?
Well, I used the same N95 for 3 months in a row.
Oh,
So there's that, because I was told there were no more, and I actually went looking for them and could not find them. So there's that.
The ones that we were issued at first were expired.
Yep. At the company that he and I were working at, nobody had been fit tested for an N95 as long as I had been working there. So
Yeah.
if you just didn't know, then I guess you just guessed, and we're like, yeah, that feels like a good seal, maybe, against particles that I can't see. But there's that. Yeah, I mean, where we were working, nobody was getting routinely tested. We weren't doing anything to stop spread by preventing people from switching stations or anything like that. There were no protocols. I had offered the management, said, hey, this is literally what my degree is in. It's in public health. It's a master's of professional studies in public health preparedness. Would you like me to come up with some protocols or something? They're like, no, we're good. We'll figure it out. I'm like, all right, well, I guess I'll go climb a tree then.
Why would you use the resources you have at hand? That's ridiculous.
Because using those resources is going to wind up affecting your bottom line and cost you money out of pocket.
It threatens the status quo.
Right.
It's EMS. This is the way we've always done it. Why would we change? We still do, standing takedowns and, C-collar and spine board everybody. Because, 1998 called and they want their protocols back.
Right.
2 liters of normal saline running wide open through, large bore IVs. Pasta water.
For everybody. All the time.
Here's some pasta water. Here's some mask trousers.
Yeah. So the safety issue regarding COVID-19, let's just call a spade here. It sucked. I remember Coop and I saying at the start of all this, because we were tracking this in December. Second it popped up on my radar, I was like, this is going to be a problem. Because we were looking at China and I'm like, this is spreading fast. Real fast, and people are getting sick and people are dying. And I said, people in EMS are going to die. And we just accepted it. We're like, well, still coming to work because I can't not come to work because, I have to live. I have to risk my health and safety so that I can continue to risk my health and safety.
And I mean, it was rather telling that near the beginning of the pandemic, one of the most often asked questions of EMS providers to EMS management was, if I get this and die, is it a line of duty death? So this way that that your kids are taken care of. Because there ain't no retirement for you. That's the best you can hope for. The best I can hope for my kids is to catch 2 to the chest on a call. Because
when you're 70, right.
Right. I mean, or whatever. I mean, you don't really get to pick your time, do you? I mean, if you did,
well, I mean, I say that's the best you can hope for is that you're older and your kids.
Right, I know that's the best you can hope for.
Yeah,
but I mean,
literally, I hope I die when I'm old.
It comes down to the best thing that you can do for your family is to actually die on this job in the course of doing your job. That is the way that you can secure the best payout.
And hope that the insurance company doesn't find a loophole so they don't have to pay it out.
Right.
We could not get a straight answer as to whether or not, if we got COVID, if we would get workers' comp while we were out.
Yep.
Because the question was then obviously you weren't using your PPE. Obviously you weren't doing this or that. Are you absolutely kidding me?
That's ridiculous. Even the drugstores and all the different places I've either talked to people or worked, we're like, if you get COVID, we're going to pay you for at least 2 weeks during your isolation. At the very least, we'll reassess at the end of the 2 weeks. And if you're still sick and it's notated, doctor, blah, 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 we'll give you an extended amount of time. Yeah, God.
Pizza parties and shit like that are cool. Thank you. We appreciate you. But what I would rather do is be paid and be given the resources to do my job. Give me the N95. Give me eye protection. We never even got eye protection.
Yep.
Yeah,
did you guys have to go out and buy your own?
I legit showed up to work
with
one time with a plague doctor mask because it had I swear to God, I legit it's on my Twitter. That photo was taken while at work because I says to my supervisor, I'm like, hey, if I bring my own mask, can I use that? Or do I have to use these company issued ones? The ones that, expired 3 years ago and the straps are so dry rotted when you try to pull it over your head, it snaps. He's like, oh no, if you've got it, you can. So I showed up in a plague doctor mask and I was like, well, I've modified this to be an N95 carrier. It's superior to, at least aesthetically and in every way because it has the built-in, eye protection. I got shot down for it, which was, kind of what I expected, but it was more to show the point of this technology is actually superior than what you're giving me. This is the problem.
I had a team leader in the Army who, one of the most valuable lessons he ever told me is the only way to mock the standard is to exceed the standard, is to go so completely overboard with one example is we weren't allowed to wear ankle socks for physical fitness training in the Army. We had to wear crew socks. So he came in with like thighs. It was like it's longer than an ankle sock, so like it's technically allowed. And I have found that holds true in EMS too. It's a paramilitary organization where, okay, if we're going to have this sort of command structure, stupid as it may be, this is how we have to behave in order to affect any kind of change. So bringing in a plague doctor mask, hilarious as it may be, at least made somewhat of a point. I'm not sure that they got the point, but the point was made.
Yeah, well, some of them got it. Some of them got it. You know, the medical director got it.
Well, yeah.
So the question is, I guess, how do we move forward? For people who are in EMS, what can they do? And then people outside of EMS, like other hospital providers, other healthcare workers, how can we help out? What are our next steps?
I have one very easy suggestion.
I want Lily to answer that because I just saw a little thing on the corner of her mouth. She's hiding in shadow. But you saw this little bit at the corner of her mouth. She had an idea.
Yeah, I want Lily to be able to contribute.
Like, I just want respect at this point. Like, if I ask a nurse, like, hey, can I have like a Toradol? Like, just and then like give it to me right away. Like, let me go on with my job and let me get out of your face. But like, just give me the respect that I deserve.
That would go a long way.
Yeah, if I'm going to be disrespected to my wallet, you could at least be respectful to my face.
Right. I would like to put out there for the general public. If you have a splinter, don't call 911. If you cut your toe and you can stop the bleeding enough to get your ass to the hospital, wrap it up with something. Don't call 911. Yeah. Don't call 911 every time that, I sneezed. Don't call 911. That's if you're incapacitated enough that you cannot help yourself to an urgent care or a hospital. It's not a Band-Aid service. Quit treating them like one. They end up running around a lot for Band-Aids. Make sure it's emergent. If you don't know what is considered emergent, Google it. It's on Google, I promise you.
That was the best part of COVID is people were like, well, maybe I shouldn't go to the hospital for this. I'm like, thank you. You're right. Yeah. You shouldn't. But I can't say that. I can't say you are not sick enough to go to the hospital. If I had that power, believe me, I would do it. I understand that it would absolutely be abused by people. But I wish that I could tell people, no, you don't need to go to the hospital for this. Are you kidding me? But at the same time,
just because you arrive by ambulance does not mean that you bypass the waiting room.
I will absolutely tell the hospital to put you in the waiting room.
Somebody stop this video right here, rewind that, and play it again. Because you call 911 and arrive at the emergency room by ambulance does not absolve you from going to the waiting room.
We will tell them to put you in the waiting room.
Lied. Because I can put your ass outside through triage faster than anybody in this county.
Yeah. Harrisburg, this is 1-5. I have a triage appropriate 38-year-old male with a tummy ache. Like, that's an actual call that I had last week. 38, grown-ass man with a tummy ache. He's got a case of the tummy troubles, if you will. And he called 911 because he thought that he would be seen faster.
Did you give him a blankie and a pillow?
I told him to sit his ass in the captain's chair. But, he said, don't I get to go on the stretcher? I said, no, that's for people who are actually sick or injured.
Good for you. Good for you.
By
the way, just because you go in through the back of the emergency room doesn't mean you're still. You will sit there in a chair. You will sit on a cot. You will sit on a bed or something in the hallway, and you will still wait your turn because it is not emergent. It is not an emergency. You will sit and wait.
Yeah. Well, the system is abused.
Oh, yeah.
Okay. And depending upon the demographic on where you live, right? Like where Mike is running now is where I used to run. right? And when you have an impoverished demographic that doesn't have reasonable access to healthcare, and they're using the emergency room as their PCP, this
Yes.
is, this is just the reality of the situation that we're in. And it really can't be, you can't deny those people, what limited access to healthcare they have.
Sure.
Right. I mean, some of the people are legit over the top sick.
That was one of the things, Coop, I wanted to bring up, but thank you for reminding me. One of the problems we have is these rural areas, they have nothing.
Right.
They might have one or two guys that volunteer when they're not at work, in the evenings or something. They have no resources. Right. So I had a friend, my best friend growing up, we met when we were 5 years old, and she was out at her father's place in a rural area with her husband. Her husband had a fucking heart attack on top of a hill. He was using a grader to smooth out some land, had a heart attack. They brought him down. She yanked him out of the truck. She's doing CPR on him. He's vomiting in her mouth. 45 minutes. 45 minutes. He died. He died laying there with my best friend pumping on his chest saying, "Please don't die on me. Please don't die on me," to her husband. Because there was no EMS anywhere.
And this topic of the hospital ending up being primary care can go in like 6 different directions, where one, mobile integrated health / community paramedicine is a thing, but a lot of the time it's used by hospital-based EMS systems to prevent readmission.
Right. Yeah. Well, I mean, they'll give it to the CHF patients so they don't come back, and they don't have to take the payment hit on the readmission from a recent diagnosis.
Because Medicare won't pay again for the same issue if it's within 60 days. By the same token, it's not, you're not running sexy calls. You're not even running calls. You're playing, house visit as sort of like a almost doctor. There's plenty of ground that we could be doing with that, but the issue is you have to pay. You have to pay these people to want to do it. The other thing that I was thinking when you're talking about rural areas is now you're talking about getting into aeromedical shit where it's literally $10,000 for that helicopter to go wheels up and not even do anything for you.
Mm-hmm. Mm-hmm.
Yep.
$10,000. So like putting aside the ground ambulances where we have people where I work now who are like, I don't know if I can afford to call an ambulance. I can't afford an air ambulance. I can't afford a medevac. Are you kidding me? 215-940, you're in service. Like, leave me alone, please. Do I choose to be saved so that I can spend the rest of my pathetic life paying back this debt? $10,000 to go wheels up. I didn't ask for that. Take me by ground. Just leave me here. I mean, I'd rather. Yeah, I mean, there are times I wish that, like, would you like to call you an Uber to an urgent care instead of going to the hospital? I would never do that, but the thought has crossed my mind.
Yeah.
Yeah, I was in a rural-ish area about 50 minutes outside of Columbus, Ohio, and the hospital there was pretty much Band-Aid and broken bone. Mm-hmm. And my partner, who I was talking about, got intubated. That day, I had to rush her into Columbus. I was driving down the highway with the state route with my blinkers on, going about 85 because I didn't want her to die at that hospital. That was horrible. And we couldn't afford anything like some kind of private ambulance service to take our asses all the way in there or anything. So she's there with Strider next to me, struggling, breathing. And I'm driving like a fucking maniac at 10, 11 o'clock at night, flying down the fucking road, and got her to the nearest EMS station that serviced that hospital. And just to get her to a good hospital that would take care of her. And I mean, it worked out fine, but at the end of the day, but that's how it is.
There's so many problems with that situation. I wouldn't even be able to start addressing them.
And it's the same thing with EMS though. Like we talked earlier, like there are some absolute idiots who have the same patch that I do. And I've told Coop before, like if I need an ambulance where I'm living, I want to know who's coming first because I need to decide whether or not I'm going to drive into the next municipality and try my luck there.
Yep.
But as for my thoughts on how to fix
one
this,
hospital in this area, if they put a bracelet on my wrist and refer to me as a patient, being as it's in print, I'm going to sue them for libel. Like, I just won't go there.
My thoughts on how to fix EMS, that could be a whole another couple hour long video, but the too long didn't read version is one, begin to pay providers what they deserve.
Mm-hmm.
Second, get rid of the bad ones. Third, make it harder to get in. Make the requirements, make medic school difficult again. Can I put that on a hat?
Yes.
Make medic school difficult again. We'll make it red, white, and blue just to have all the bases covered.
No, make it green and yellow. This way you have the contrast and you can tie into the green ribbons that they put out every time one of us decides they're going to
This isn't a British ambulance. We're not doing green and yellow. We're not playing with the high-low here, although one of our trucks does have a high-low and it's adorable. Yeah.
I love those.
But like that those are three big things, and it's sort of a chicken and an egg thing. Like do we get more people first and then raise the difficulty and then raise the wage, or like how do we do this? Because something has got to give first. Either we have to be paid more and that's how you get more interest, or we have to have more people in order to justify raising the wages, or more skilled people to justify raising the wages. A lot of people will say college and like actual academic requirements, which I'm not against, but that's a lot of money that you're paying up front or with interest down the road that at the current wage, none of us can afford. The only reason I was able to afford to go to get my bachelor's was the GI Bill. The only way that I was able to get my master's is because my dad left me money and I decided to save it for school. Yep. Like instead of blowing it on a car, which believe me, I would really like a nice, 1970 Chevelle, but that's not really going to do anything for me in the long run. Yep. Besides look cool.
If anyone else has any last thoughts on this last question, otherwise we can start wrapping it up. Does anyone have anything you want to tell the audience before you go? Just kind of last words from everybody.
If you're in the medical field and you are interested in doing EMS research, please involve EMS providers in that research. Like, I don't care if you have to hold a paramedic's hand through the research process. If you can find somebody who's smart and interested in it, you will probably change their perspective on a lot of things. And they will probably continue to do that research, which I feel like more research needs to be done from within the community instead of from the hospital side looking in. A lot of the time it feels like we're in a fishbowl when it comes to that sort of thing because nobody on the inside's doing any publishing. I'm trying, but like what I wrote isn't necessarily suitable for any kind of publication right now. It's too specific. It would be better off going towards like the local government. The one that I want to do, sure, that has plenty of, application, but it's just getting permission to do it from my employer. So if you're on the hospital side and you're like, hey, this might be an interesting topic, team up with some people who are actually doing it instead of just fishbowling them. That's my 2 cents.
Yeah.
Absolutely. Lily, do you have any parting words for the audience?
I think, again, if we're talking to the healthcare community, like I know we are all burnt out right now and we're all on our last string, but we're doing all of this. We have to deal with so much more BS than all of you have to do when we're doing it in a tiny box in the back. So if we come in and we didn't check a sugar, there's probably a reason why. The patient was probably combative and said they didn't want to be stuck. And you were like, okay, I'm not going to risk my own health. So don't question why we do things.
All right, Coop.
I think I'll take a rare opportunity here to just say, thanks for putting this together, Ben, and putting this on, and giving us all the opportunity to get some of this out here. Because nothing I'm going to say here to the overall medical community hasn't already been said before. It is the same issues. It's been the same issues since Moby Dick was a minnow. That it is the same issues. That I think that probably says everything that we really need them to start understanding, because you've already been told this. So quit being dicks and figure it out. There you go. That's my message to the overall medical community with regards to EMS. Quit being dicks to us and figure it the hell out.
Absolutely. B, what you got?
To reiterate, EMTs are not your chauffeur to the hospital. Don't call them over stupid shit. That consumes so much of their day that they are exhausted and they don't get a break, and they end up eating gas station or emergency room food, which is not good for them, but you don't have time to stop and get anything healthy. It's just the way it is. You can't store it in the ambulance. There's just no room. So, most I've been in anyways. Don't use ambulance services as a chauffeur to the hospital. Call Uber or something. Call a friend, have them take you. Also, do not assume that EMS are like cops and don't care. No one is an EMS that doesn't give a shit, because you don't get paid good enough to not give a shit and be there. They're all doing it because they care. They all want to help. They all want to make a change. They all want to save lives. So show them that courtesy. And by God, the last thing I'm going to say is, someone's running with fucking lights and sirens. Get the fuck out of the way. It's ridiculous. You going to the store is not as important. If everybody think of it like this, if that was your grandmother or your father, pick your favorite family member in the back of that ambulance, would you want everybody to move? It might be, and you don't fucking know it. Get the hell out of the way. That's it.
Absolutely. Well, thank you to everyone on my panel for being here today. I know it was kind of early, but this was a video I'm really passionate about. I think anything that we can do to make medicine better for everybody, and that includes the staff, because the more safe and the more safe that we are, and the better we're doing mentally, physically, all that, the better we can help our patients in the long run. So thank you for being here. And this kind of let me know that we might need to do another video on this, because we only just scratched the surface on a lot of these issues. But thank you all in the panel for joining me. Thank you, everyone in the audience, for listening. And we will see you all next time. Later.
Thanks, Ben.